Good evening to everyone present here with us today. This is Shreyan from IDCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Anita Khan. Ma'am is MBBS MD, Obstetric and Gynecology, Fellow of Indian College of Gynecology, Chairman OBG Service at Asian Institute of Medical Science, Faridabad. With the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is menopause management. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her. Over to you, ma'am.
Good evening, everyone. Today, I will be talking about menopause management. I'm unable to move my slides.
Ma'am, there are arrows, the right arrow and left arrow. Once you click on it, the slide will start changing.
It is not happening from my end.
Ma'am, just click on that escape button on your keyboard.
Yes. Now should I be able to do it?
No, ma'am. It is the still like we are getting the full screen view only.
Some hitch here now.
Yeah, yes,
No,
ma'am. Yes, ma'am.
yes. I'll do it on
Yes.
this only, right?
Sure. Not an issue.
Yeah. So menopause is defined as the time of cessation of ovarian function resulting in permanent amenorrhea. As the ovarian hormones decrease, the uterus does not bleed, and it takes 12 months of amenorrhea to confirm that menopause has set in. So therefore, menopause is a retrospective diagnosis. Before the actual menopause sets in, the ovarian activity goes on decreasing, and that is called perimenopause because the hormones are sometimes acting normally, sometimes they are decreasing, and this phase is also called the climactic. The age of menopause naturally occurs between 45 to 55 years of age. Average age in India is reported to be 46.2 years, whereas when compared to the Western world, it is 52 years. Menopause setting before this naturally is called a premature menopause. And before 40, we need to treat it because it leads to primary ovarian insufficiency. If we divide menopause into three parts, the early part, the woman can have hot flushes, sweating, insomnia, menstrual irregularity, psychological symptoms sometimes. In the intermediate part, which can result till the early 60s, because of lack of hormones, a vaginal atrophy will set in. There will be dyspareunia. There may be some urine problems like urge incontinence. The skin will tend to atrophy, while in the late menopause, many aging problems also add up, leading to osteoporosis, atherosclerosis, coronary heart disease, and cardiovascular disease, Alzheimer's disease. These all impact the quality of life of the woman. So we see starting from hot flushes, night sweats, changes in periods, weight gain, problems with bladder, vaginal dryness, loss of interest in sex, mainly because of the vaginal dryness, mood changes, sleep disturbances, and also forgetfulness, headache, backache. The hair disappear from the head to some extent and appear new hair appear on the chin, and ultimately muscle and joint pains set in. So once we know that menopause is about decreasing hormones, why don't we give menopausal hormone therapy and take care of the patient's problems? Because there are certain fears which the doctors and the patients both have. The fears are about breast cancer, increased risk of CVD, increased risk of venous thromboembolism, and of course, we Indians do have a lot of hormone phobia. Then confusion is also there because we don't know which kind of therapy to give. Do we give a break of 7 days? Do we give hormones or we don't give hormones? Whether we give both the hormones together or we give them in a sequential manner, which estrogen to use, which progesterone, what dose, what route, how long, when to start, when to stop. Some of these problems I would like to address over here. Mainly, age is the major determinant of the risk and the benefit of menopausal hormone therapy. So, less than 50 years, the benefits will far outweigh the risk of giving menopausal hormone therapy. 50 to 60 years, we have to actually decide whether the benefits are outweighing the risk that will happen because of a long hormone therapy. More than 60 years, the risk will equal or be more than the benefits gained. So it is better to go for alternate therapies. So what are the benefits that we get with menopausal hormone therapy? It reduces the vascular motor symptoms or the hot flushes. The genitourinary system problems like atrophy, dyspareunia, they are taken care of. Osteoporosis, fracture risk decreases. There is a reduction in the CVD risk, especially if the woman is less than 60 years of age. There is a reduced risk of developing type 2 diabetes mellitus. The abdominal obesity is reduced. The cognitive impairment is prevented. Neovascular macular lesions are reduced. Risk of colorectal cancer is reduced. And also, this will lead to improvement in quality of life. While the risks are stroke, venous thromboembolism, uh, not development but promotion of a already existing carcinoma in breast, CVD if the woman is more than 60 years of age. So we have to take a really judicious decision, right woman, right hormone therapy, right age, right dose, and right route. So again, the risk factors for MHT users, besides the age, which should not be more than 60 years, obesity, definitely the effect of the hormone is less. Insulin resistance, again, the effect of hormone will be less. And there is an increased risk of cardiovascular events if there is a pre-existing hypertension, diabetes, smoking, or dyslipidemia. If there is a family history of venous thromboembolism, again refrain from using MHT. So in the presence of any of these, a cautious approach is required if at all you want to give MHT. So beside asking the patient about the history of any medical treatment, also look into what medications they are taking because sometimes patients are not even aware in India what treatment they are taking for which disease. When to give MHT in case there are vasomotor problems or some psychiatric problems associated because of those hot flushes, definitely it will help the woman. Estrogen deficiency syndrome can be organic, where urogenital atrophy will happen. It may be metabolic, where osteoporosis can result. Expected effects of long-term administration of estrogen lead to prevention of Alzheimer's and Parkinson's disease if started early and given for the first 10 years after onset of menopause and before 60 years of age. Prevention of senile macular degeneration and geriatric blindness may be there. Geriatric tooth loss and improved is better, and improved oral health is there, and colorectal cancer is always prevented by MHT. What are the contraindications where you do not give MHT? Current or past breast cancer, estrogen sensitive benign or malignant conditions, undiagnosed genital bleeding, untreated endometrial hyperplasia, current or past arterial or venous thromboembolic disease, untreated hypertension, active liver disease, porphyria cutanea tarda. So, how to start with the treatment? First of all, a detailed history, examination, listing of all her problems. One has to assess if MHT is right for that lady. The timing of the therapy is very important. Like I said, in the first 10 years after menopause, at which age post menopause MHT started affects the relation with coronary risk because it may affect in the early years, but it may actually increase in later years if given continuous dose of MHT is given. MHT is appropriate for relief of vasomotor symptoms in early menopause and it is not recommended for chronic disease prevention. Check the BP, blood sugar, BMI, waist circumference, do the lipid profile, ultrasound, the BMD, and a mammogram. The points to remember, some points may be repeated again and again, but that's just to tell how important they are. MHT is highly efficacious in suppressing vasomotor symptoms and the urogenital symptoms. Young women with premature menopause deserve MHT till such date, 42 or 45 years, where they would have had a natural menopause. Cyclical estrogen therapy with add-on progesterone is a must in case of intact uterus. So this one has to remember always. Transdermal administration is preferred in case of oral treatment intolerance or presence of any risk factor. Better bioavailability is there and facilitates a long-term balance of the estrogen levels at physiological level, and the ratios are maintained if transdermal route is given. The newest application method is metered dose transdermal spray, which is not yet available in India. So let's go to various types one by one. Vasomotor symptoms. Vasomotor symptoms in menopause are associated with sleeping disorder because all time she is having hot flushes. Concentration is not there, lower quality of life is there, and overall health suffers. They can last for up to 7.4 years on an average. Start with the lowest dose of estrogen. Maximum effect is obtained within 6 to 8 weeks, and if no relief, then you can increase. Problem may return in about 50% of women after stopping the treatment. It has not been proved whether the dose should be tapered off or stopped abruptly because recurrence is seen in some in both the ways. Besides that, there are certain other advantages like chronic insomnia will improve with the MHT. Estrogens have a positive effect on sexuality by resolving the vulvovaginal atrophy and also reducing the hot flashes. Transdermal estrogens are preferred in women with low libido because they will not go via the liver, and the serum hormone binding globulin will not attach to testosterone, and more testosterone will be available for libido. So with MHT, the course of inflammation and regeneration of epithelium is modified by estrogen. So skin gets and looks better. So that is why many women before WHI preferred MHT because it made them glow. Dry eye syndrome risk increases, but cataract and glaucoma decrease. It prevents bone loss and reduces the number of fractures in all locations. Virility syndrome and sarcopenia are corrected positively. Lowers the onset of type 2 diabetes. It prevents fat accumulation by stimulating the alpha estrogen receptors. Definitely, when all these effects are happening, the mood will improve. Positive effect on menopause associated depression would be there. Cognitive function improves, but only with an early start within the first 10 years. If hormone therapy is started after 65, it will actually increase the risk of dementia and Alzheimer's disease. The positive effect of MHT on ischemic heart disease is seen if started within 10 years of menopause and it until the age of 60 years, and there is a negative effect if started after that age. Mastodynia, fluid retention, nausea, lower extremity cramps, and headaches may occur, especially in the early phase of usage of estrogen. Long-term use of MHT, which is more than 10 years, increases the risk of breast cancers by 10 to 30%. Estrogens per se do not induce breast cancer as oncogenes, but may become the promoter of its growth. So that is why WHI did say that breast cancer increases, but most of the cases that were detected in that study were at a very early level, and very small lumps could be detected because uh, it just augmented those cancers, and women could pick them up early because they were told to be careful about it. The influence of MHT decreases with increasing its BMI. MHT significantly increases the risk of thromboembolic diseases. Endometrial cancer may arise in women with intact uterus when only estrogens are given. Estrogen therapy is the treatment of choice for genitourinary symptoms. Start with low doses. Local use as creams or tablets or vaginal gels or rings are preferred. Most appropriate dose of hormone therapy depends on the woman's phase of life, age, and general health status. So when a woman is more than 60 years old, or more than 10 years in menopause, or there is a high risk CVD, then don't give MHT. In an obese woman with a moderate CVD risk, yes, you can give. And in case there is a low CVD risk or recently postmenopausal woman is there, you can definitely go for MHT. In diabetes and menopause transition, various studies have shown that type 2 diabetes mellitus decreases if this therapy is started by the age of 40 years, not later on. So now we come to surgical menopause. Surgical menopause happens when removal of both the ovaries is done, and a woman suddenly loses all her hormones, and sudden and severe onset of menopausal symptoms may be there, and naturally sexual function, loss of fertility is also there, and increased risk of osteoporosis and cardiovascular disease is there. Then MHT is advised for all women who undergo a surgical menopause under the age of 45, provided they do not have any contraindication to MHT. In case of venous thromboembolism risk, these events are most prevalent adverse effects of oral estrogens in recently postmenopausal women. Oral estrogen therapy is contraindicated in them, and a careful assessment of personal and family history is advocated before we start the hormone therapy. Now, coming to which kind of hormone therapy, what are the special problems and the treatment? As I said, post hysterectomy, you can give only estrogen. If uterus is intact, give estrogen and progesterone. If there has been a history of endometriosis, though the ovaries may be removed, progesterone needs to be added to estrogen. Serms like Tebolon are a good choice. They do help in libido, preventing the bone loss, osteoporosis, and also do not affect the breast. Dydrogesterone and micronized progesterones are both effective and better than the synthetic progesterones. Treatment with estrogen alone has been found to increase the endometrial cancer. So, all those women who have an intact uterus, or all those women who have an intact uterus but have undergone TCRE, they do need to take progesterones along with estrogen, so that whatever is endometrial lining is there, it does not undergo a endometrial cancerous change. Women who have had a hysterectomy do not need progesterones. Monotherapy is enough for them. Coming to endometriosis, it has been said that hormone therapy may increase the risk of endometriosis symptoms and disease recurrence after surgically induced menopause. Few data suggest that a higher risk may be there in whatever is left of the endometriosis after surgery. Postmenopausal women should be consciously evaluated before starting MHT in those who suffered from endometriosis. Patients with endometriosis receiving MHT should be monitored regularly in case that pain recurs. That would mean that the disease is coming back. In the genitourinary syndrome of menopause, the symptoms are genital dryness and decreased lubrication during sexual activity, dyspareunia, postcoital bleeding, and loss of libido, dysuria, urinary frequency and urgency, itching, irritation, and burning sensation at the level of vagina and also vulva. So they need local vaginal estrogen, which can be used in the form of estrogen gels, estradiol gel, estradiol vaginal tablets or gel. They are to be used once daily for 2 weeks, and then followed by twice a week for another 2 weeks. Recurrence is common on discontinuation. Progesterone is not required when we are giving local therapy, and they need a long-term therapy at least up to 1 year at a stretch to be able to take care of the problem. So International Menopause Society in 2016 said that urogenital symptoms respond very well to estrogen, and vaginal route of administration is the best. Long-term treatment is often required as symptoms can recur, and systemic risks have been identified with local low potency, low dose estrogen as minimal only. So one need not to worry about them. Now, coming to the main part, the premature ovarian insufficiency and premature menopause. Due to various conditions we find, which may be genetic, autoimmune, or induced, that a woman may go into premature menopause. And in such a woman, it is always better to start therapy. It is actually highly recommended to start MHT till 40 years of age minimum, and if possible, till 45 years of age. So all those sequelae of POI, premature ovarian failure, are the ones which we have talked about menopause, and all these conditions can be very well controlled by treating them with MHT. They can be, if the uterus is there, then estrogen and progesterone combination needs to be given. If uterus is not there, then definitely one can only go for estrogen. The metabolic syndrome, which we find in today's, it's increasing in today's population, which may be seen in the form of PCOS or metabolic syndrome. All these conditions, preeclampsia, one part of this group of metabolic syndrome may be premature ovarian failure. And these women also then need to take treatment for their premature ovarian failure in the form of estrogen and progesterone if their uterus is intact. If not, then they need to be given only estrogen. So start therapy as estrogen only if there is no risk of carcinoma breast. All those things that I told you about the contraindication need to be ruled out, and a sequential treatment can be given. Initially, if the uterus is intact, there may be some amount of bleeding, but generally it goes away. And in case the woman is long post menopause and she has come to you after maybe 2 to 3 years, then a continuous combined treatment may be given. In case of breast cancer, like I already told you, it may promote the growth of a pre-existing cancer that may not have been picked up. Assess the risk of breast cancer by taking a history and suggest non-hormonal therapies over MHT so that we do not act by giving more cancer to a woman. Now, what are the MHT formulations? As we can see, this is what I have been talking about, whether we can give continuous estrogen or we can give cyclic, where the first half only estrogen is given and then progesterone is added if there is a uterus which is intact. Continuous sequential HRT, where till day 14 estrogen and in the next 14 days progesterone is added. In this, there is no tablet break, and bleeding will happen in the first half in the next packet where only estrogen is being given, and there may be a continuous combined HRT which may be in the form of estrogen or progesterone. This can be given orally, and nowadays we are getting patches and creams which contain both estrogen and progesterone, and they can be given via the skin also. So, pharmacological options are hormonal therapy, which may be MHT, non-hormonal therapy, which may be in the form of some antidepressant. Fluoxetine is the one which is used most commonly. Anti-epileptics like gabapentin and pregabalin, they take a lot of weight off the problems of vulva and vagina. The vaginal burning and the vulvodynia go away with that. Complementary and alternative therapies like phytoestrogen, isoflavones can give, although the data is insufficient for proving their efficacy. These are some of the preparations where we can, see which estrogen gives how much and what is the equivalent dose of which kind. Various preparations which are available in India are like conjugated estrogen, ethinyl estrogen, that is Premarin tablet. Then we have estradiol valerate available as Progynova tablet. We have Tibolon, which is now available by the name Cibalon. Estriol, which is Evolon tablet. Estradiol hemihydrate, which is Estravet. Then we have medroxyprogesterone, norethindrone, micronized progesterone, and dydrogesterone, which are the various progesterone formulations. And it has been said that micronized progesterones and dydrogesterone are more favorable because they are more like natural progesterones, and the synthetic ones have more of side effects. For the difference between the natural and synthetic form, multiple trials have proved that synthetic form of estrogen and progesterone cause increased risk of stroke, CVD, and carcinoma of breast. So, only available combined MHT in India is by a particular group, which is Femastone. They are giving in all kind of preparations. And the other options that we have to give MHT or replace MHT is Tibolon. It is a progestogen with selective estrogen activity and weak androgenic activity. So it is effective in treating the vasomotor symptoms very well. Urogenital atrophy is also treated very well and protects the bone mass, although not very effective, but still very well. But increased risk of stroke is there. Then there's another term, raloxifene. This is mainly used for bone health because it leads to decrease in osteoporosis. Other effects are not seen. Then ospemifene is it helps in dyspareunia by acting on the genitourinary system. But it increases the hot flushes and endometrial hyperplasia. Bezidoxifene is very well accepted these days, and it is accepted in combination with the conjugated estrogen also. It reduces the bone loss. It is used for vasomotor symptoms with combination with estrogen. Side effects are many like muscle cramps, but still, this is the thing which is being used these days to take care of symptoms. Clonidine is basically used for vasomotor symptoms only. Phytoestrogens are non-steroidal compounds. They occur naturally. There are three main types. More studies are required to be able to label that they are very effective for treatment. They are also called bioidentical hormones, but because they are plant derivatives, many people are more accepting these treatments than the hormones, and they feel they'll be cured by it. But somehow this is yet to be proved, and because the dose in a tablet or oral or local form is really not conclusive of how much estrogen or how much of hormone is being released, it can sometimes lead to adverse effects also. Nowadays, lasers, microablative, fractional CO2 and non-ablative lasers are being used as a modality for treatment of genitourinary symptoms by acting on the vaginal epithelium, wherein very positive effects are seen. So, parameters that we use is for vasomotor symptoms, transdermal are very effective. VZD plus CE is effective, and we find, but the best is estrogen oral with or without progesterone. In genitourinary symptoms, all three forms are equally effective. For carcinoma breast, actually they are saying no significant risk if we have proved that there is no pre-existing small focus of carcinoma in the breast. Endometrial safety is proved if we give progesterone along with estrogen. We know thromboembolism, there is no significant risk unless there is a prior history. CVD, there is a reduced CVD risk in all kinds if given for the first 10 years after postmenopause, and bone health improves. So there are so many good things that happen, and nowadays all menopause societies, they give recommendations as per their own population to be used whenever a problem arises. So as per the Indian Menopause Society, estrogen therapy is approved and this is the treatment for vasomotor symptoms. Patients with persistent and severe hot flushes, HRT is the most effective intervention. HRT should be used for the shortest duration of time necessary to control the symptoms and at the lowest dose. The short-term use, that is less than 5 years, of estrogen and progesterone are not associated with any significant risk if all the contraindications have been ruled out. Estradiol is the first-line estrogen, oral or transdermal, in a cyclic regime. Progesterone agent should be added for the last 10 to 14 days where an intact uterus is there. Only very small percentage of women continue to suffer from hot flushes 10 years after the onset of menopause, Therefore, longer HRT may be appropriate in these women. A treatment should be periodically evaluated to determine if it is still necessary and stop if there is no need. While prescribing HRT, its contraindication and adverse effects should be kept in mind. Similarly, other associations also give appropriate instructions. There is a definite role of good nutrition and maximizing the basic nutrient intake, and besides that, lifestyle modifications like giving up on smoking, alcohol do help the postmenopausal woman. A healthy lifestyle with lots of exercise, mainly weight bearing exercise in case they are at risk for osteoporosis, is recommended to all women. Now, how to follow a patient who has been prescribed MHT? Schedule a follow-up appointment after initiation of MHT regimen in 1 month to assess whether treatment is helping. Adverse effects of MHT include bloating, breast tenderness, increased blood pressure, headaches, and fluid retention. When to stop? A regular monitoring of MHT is advised with adjustment made to the type, dosage, or route of administration according to patients' changing circumstances and the treatment goals. To conclude, the general trends are individualize the treatment. What does the woman need? What is her problem? What are the indications in her? And on the other hand, what are the contraindications? Does she have any risk factor? Then you decide what to give her. Minimize the dose, start the therapy as early as possible after menopause, and when these rules are observed, benefits will always prevail over the risks. And in the end, I would like to say right woman, right MHT, right dose, right route for right duration. Thank you.
Thank you so much, ma'am. So, ma'am, we have few questions from our audience if you like to pick
Yes,
that up.
yes, definitely.
So, ma'am, the first question from our audience are there specific CAM modalities that have shown promising result in relieving menopausal symptoms?
Pardon, which modalities did you say?
CAM, CAM.
I did not get it.
Ma'am, it is CAM.
CAM modalities.
Yes, ma'am.
I did not understand what the question means, you know. There are various modalities available. You can give it by oral route, you can give it by vaginal route, you can give it the giving the hormones, you can give them while the via the skin in the form of jellies, patches, if this is what they want to know. And patches and jellies are available, and even the vaginal gels, vaginal tablets, vaginal rings are available, which contain only estrogen and progesterone. Both combinations are there, which can be used easily. And depending on the dose, the tablet may have to be inserted every day, or the ring may have to be inserted every week. And accordingly, the tube may be applied every day, or the patch may be applied every week. And then a week free of treatment is given for in case the uterus is there, the withdrawal bleeding may happen. So these are the modalities of giving MHT. I have understood this from the question.
Thank you, ma'am. So, ma'am, another question from our audience is, what are the current understanding of relationship between menopause and cardiovascular health, and how does this influence your approach to managing menopausal symptoms?
See, cardiovascular health definitely goes down as estrogen waning in the body happens. But continuing to give estrogen for protection of the cardiovascular system is not effective. This has been done by the menopause study, which was taken up in early 2000, and they found that it has so many side effects if given without any indication, and just protection for cardiovascular system is not enough unless it is given only in the early years post menopause. So nowadays we restrict menopausal hormonal therapy only to vasomotor symptoms, to genitourinary symptoms, or to there are other options available for osteoporosis prevention or treatment. So naturally we do not recommend MHT for that. And if it is given only for cardiovascular system, it really doesn't work. the basic role that happens because of estrogen is that the triglycerides decrease, and we want postmenopausal women, we want that their lipid profile should be as close to normal as possible. And there are so many other drugs available which can do it, and which do not have as bad effects as estrogen when given for a long time. So we avoid giving it for cardiovascular diseases.
Thank you, ma'am. The next question from our audience is, can you discuss any novel approach or inventions for preventing cardiovascular disease in menopausal women?
And now they are coming in with sprays which can be used on the vaginal area or on the skin, which will deliver the hormones inside the body, and it will bypass the liver. And naturally, once the estrogen level goes up, it will uh, bring down the cholesterols to as close as to normal as possible. But this is not recommended as of now, because so many other drugs are also available.
Thank you, ma'am. So, ma'am, the last question from our audience is, what strategies do you employ to assess and manage bone health in menopausal women, considering the increased risk of osteoporosis?
A detailed history is required, about the family history. What is her working pattern? How much exercise does she do? Is she a frail person, or is she very obese? Has she taken long-term steroids for some other illness during her early life? And also, has she been on certain kind of drugs like anti-epileptics, which lead to osteoporosis? And after 65 years, a screening by doing the bone mineral density can also be done. And according to that, weight bearing exercises, adding of calcium, and where required, medicines to increase the bone density can be added. MHT is not the only option. If given for osteoporosis, it is given for a very short time, immediately after the menopause is set in. But there are very many other drugs available, although we are giving bacitractopine with conjugated ethinyl estradiol. This combination is available in Western countries, not so prevalent in India, but it helps a lot in hot flushes as well as osteoporosis. And there are drugs like alendronate. There are other SERMs which are available, which can be given, and patients actually tend to take the drugs which are more longer acting, once in 3 months, once a month, once a week, rather than taking it daily, which will help strengthen their bones also, and they won't have to, have the hassle of taking it daily, and no side effects also.
Thank you so much, ma'am, for answering all our questions. Uh, Before concluding today's session, ma'am, any last remark from you?
I'm again going to say the same thing. Don't let women suffer. If they have problems, assess them. If lifestyle modifications do not help and she's in the early years of menopause, definitely don't be scared of MHT, and don't let the patient be scared of MHT. Give her the right treatment for her problem. And many women suffer in those age groups from vulvovaginal dystrophy, and they live a life which is really hell, going to the toilet very frequently, having urinary problems, having sexual problems, and they can't even talk about it openly, because women, especially in India, are very quiet about their genitals. So we should come out more in open, contact women groups and tell them help is available, and this is the way to go about it. And I think we can make their quality of life much better.
Thank you so much, ma'am, for joining us today